Hey everyone, my name is Dr. Galatia Strong. I'm a physical therapist who got 100% on my NPTE, and this led me to co-found SPT with me, which is an NPTE prep platform. If you enjoy what you see in this lecture, check us out at sptwithme.com when you're studying for the NPTE. Now onto what you're actually here for, let's talk about the direct and indirect pathways and its association with Parkinson's disease. This schematic or flowchart is probably the one, or at least something similar that you normally think about when you're presented with the idea of the direct and indirect pathways. That's okay. However, realistically, if you're just looking at this image, it's kind of hard to tell what is going on. So at least in this lecture, I'm hoping to put the concept together with images and talking about what they are, the function, and how they all connect with each other to make this topic make sense. I want to start off with this idea that even though we normally do associate these pathways with Parkinson's disease, the presence of these pathways is actually completely normal. All these pathways is the communication between the cortex, the thalamus, and the basal ganglia. It's just a tract, so its presence does not mean that someone has Parkinson's disease. This is a good diagram to show you the relationship about how all these structures communicate with each other. Now, obviously, this diagram is not to scale, and it is not a true representation of how the brain looks, right? So clearly, the thalamus and the basal ganglia, they aren't just structures that are floating outside the brain and the brainstem, okay? At least it does give you an idea. So here in this image, you can see that the cortex, so the cerebral hemisphere, at least deep within it, it both sends and receives information from the basal ganglia. So it is not a one-way road. So how it works is that the cortex is going to send information to the basal ganglia, which in turn is going to process and integrate the information. In this picture, you can see that the basal ganglia is represented by the shortened versions of the name, as you can see. So for example, PUT is for putamen, GPE is for globus pallidus externus, and we're going to talk about these a little bit more in depth in future slides. But after this, so the basal ganglia is going to process and integrate it. It will then send information and talk to the thalamus, which then the thalamus is going to communicate information back to the cortex. So essentially, just to keep it simple, cortex to the basal ganglia, to the thalamus, back to the cortex. All right, so once again, this is a normal pathway. It should happen. I personally feel that the structures of things like the cortex and the thalamus, we just cover that a lot more in school than we do that of the basal ganglia. And for that reason, I'm not going to spend too much time on those two, the thalamus and the cortex, but I will spend more time on the basal ganglia, okay? So I will be showing several views of the basal ganglia. So let's start off with this one. I'm showing this one first because I need you to see and just remember and understand that the basal ganglia is a 3D structure. You can see that it surrounds the thalamus on both sides, and it's actually quite large. There is a connection that you can see that goes to the amygdala as well, so it does communicate with that. Now, again, I do have to show you several images because in this image you cannot see it, but there are more structures within the basal ganglia that we will talk about next in a different view of this. So that structure is here. It is called the substantia nigra, and it is present in the midbrain of the brain stem. So again, I have to show several images because that 3D image prior, it didn't really show the brain stem or anything within it. So again, multiple images for a reason. Now this structure, the substantia nigra, it probably rings a bell because this is the structure that we normally associate with Parkinson's disease. We're going to go into depth later, however, for now let's just talk about the location of all of these things. So again, the substantia nigra, it's going to be inferior to the rest of the region of the basal ganglia. However, you can see that it communicates with the rest of the basal ganglia since this image does suggest that there are projections that go toward that region, all right? Now, this is the image that we are all probably most familiar with when we start to learn about the basal ganglia. It's a cross-section of the brain. You're looking anterior to posterior. In that case, this specific image is showing the person's left cerebral hemisphere, right? It's the left side of the brain. Here you can see pretty much almost all parts of the basal ganglia that we will get into a little bit more. These are the ones that are shown in blue. Now, as you can see, even though the basal ganglia is one unit, it's referred to as one unit, they are all over the place in location. Let's talk about the actual parts that make up the basal ganglia. So first, what makes up something called the striatum is the caudate and the putamen. These are both located deep within the cerebral hemispheres, and you can see one is a little bit more superior, one's a little bit more lateral. Next, we have something called the globus pallidus. There are two parts to it. One is called the globus pallidus externus, which is more superficial than the globus pallidus internus. Hence the names just internus and externus. Next is the subthalamic nucleus. So this is a structure that I will say is a little bit more challenging to find when you are hoping to find a diagram of everything that's consisted in the basal ganglia. So the position of the structure is anterior to the thalamus. So really the only way that you're able to see it in an image or a cross-section is if that cross-section is exact to its location, right? So just remember that the basal ganglia is a 3D structure. It's pretty large, right? It goes pretty far anterior to posterior. The subthalamic nucleus is small relative to the entire basal ganglia, so it's not going to extend the entirety of the length. So that is the reason why there has to be a very specific cross-section location image that we see. So sometimes you'll just have to find another image that will show its relationship to where the rest of the basal ganglia is. Lastly, we have the substantia nigra. It's in the brainstem, specifically in the midbrain. Again, this is what we normally associate with Parkinson's disease. A problem with it is what's associated with it, not just the structure itself. We've clearly exhausted talking about the physical location of the basal ganglia, so let's move on to the next topic, which is what is it? What does it do? So the basal ganglia's job is essentially everything to do with producing physical movement. It's the integration center that allows or inhibits the planning of movement, the initiation of movement, meaning actually starting a movement, then the execution or actually performing the rest of the movement. So if you just think about it, right, Parkinson's disease totally makes sense with respect to the function of the basal ganglia because movement is a huge issue of it. You know, making a normal size, normal amplitude movement, that is the issue. People present with shuffling gait because they can't produce a large enough movement. Furthermore, the basal ganglia also has influence on things like emotions, cognition, and the reward system. So, given that there's a problem essentially with the basal ganglia in Parkinson's disease, we are also going to see these things affected: cognition, emotions, reward system, things like that. So think about the changes that we see and what we have to test as a result of that. Well, cognition, that is exactly why we test for dual task ability in these patients. Back to this image. So before we actually go through the flow chart, you have to understand once again that this pathway is normal. It is present in you and I. It's present in those who have Parkinson's disease. The problem though with Parkinson's disease is that the substantia nigra in particular does not produce enough of the neurotransmitter dopamine. That is one of its primary jobs, is to produce dopamine, okay? So you're going to see in this chart, but the release of dopamine into this pathway is one of the first things that happens. Well, for whatever reason, substantia nigra doesn't produce enough dopamine. If you think about it, our body always needs a certain level of something to function, right? If you think about our nerve conduction, you have to reach a certain voltage for the action potential to propagate. If you think about enzymes, they have to be in a particular temperature range to be able to perform its function, things like that. It's the same idea. Dopamine levels are critical for this pathway to work optimally. So if you don't have enough, then this pathway is not going to work properly. Similar idea. So just kind of use analogies or similarities between different processes to help you understand things. So even in the case of Parkinson's disease, the basal ganglia, the cortex, and the thalamus, and the pathways just in general, they are still working, okay? So know that there is not necessarily a change in the shape of the caudate or the shape of the putamen. It's not that. The structures look the same. It is purely just the communication not being able to continue on as well as it normally would because of this change and decrease in dopamine levels. I think it's time that we finally go through the flow sheet. So let's start off with talking about the communication coming from the cortex and from the substantia nigra going toward the striatum. Like I mentioned before, the striatum is made up of both the caudate and putamen part of the basal ganglia. The cortex specifically is going to give off the neurotransmitter of glutamate, which is an excitatory neurotransmitter. The substantia nigra, as mentioned before many times, releases dopamine. So right now we are going to talk about what is normal for this pathway. So at this moment, do not worry about the lack of dopamine. Do not worry about Parkinson's disease just yet. So far, these occurrences are happening in both the direct and indirect pathway. As we continue down the chart, you're going to see that the only difference really between these two pathways is that the indirect pathway has an additional few steps. So ultimately, we're going to make our way from the striatum down to the GPI and SNR, which respectively are the globus pallidus internus and the substantia nigra. Clearly, there's a lot of going to and from for the pathways. However, what you can see is that with the indirect pathway, before we get to that point, we are going to communicate with the GPE, which is the globus pallidus externus. This is going to directly communicate with the STN, which is the subthalamic nucleus. Again, ultimately we meet up at the same spot as the GPI and the substantia nigra. As you can see in the flow sheet, there's also something called a GABA. This is GABA. This is a neurotransmitter that is inhibitory, so the complete opposite effect of the excitatory glutamate neurotransmitter. Now, I will say, when you're studying these pathways as a physical therapist student, I personally would not be too worried about memorizing where the glutamate neurotransmitter is being projected to, where the GABA neurotransmitters are being projected to. If you want to memorize them, I really don't think there's any harm in doing that. However, I would say that's not really your main concern of what you should understand about this pathway as a physical therapist. Now, following this step, we are going to make our way to communicate to the thalamus, which will ultimately tell the cortex what movements we want to do and what movements we don't want to do. So excitatory versus inhibitory, right? Now, honestly, this flow chart, aside from just having to memorize everything for the first time, it's really not that bad, right? The communication, again, it doesn't change whether or not you have Parkinson's disease. The steps will always be in the same order. We are still talking about what's normal, but I do want to clear something up that tends to be confusing. So if you look at the bottom of the flow chart where it shows the thalamus and the cortex, you're going to see that both pathways show that glutamate is being sent from the thalamus to the cortex, which means that you're exciting the cortex, correct? But wait, if one of the pathways is excitatory and the other one is inhibitory, why are both pathways ultimately suggesting excitation? Well, I would think that the direct pathway is going to make sense because you are trying to excite it, which is why glutamate makes sense. However, I can see where the confusion lies with the indirect pathway. So what is happening is that even though glutamate, the excitatory neurotransmitter, is being sent from the thalamus to the cortex, this does not mean that you are exciting the cortex to elicit a movement. In fact, you are just exciting the cortex to promote inhibition, which is the job of the indirect pathway, right? So you're essentially telling the cortex, correct, yes, I do not want movement. I want to inhibit movement. It's time for the pathophysiology of Parkinson's disease. Once again, it's because of dopamine levels. Substantia nigra, the structure, is unable to produce enough dopamine. So you can see that through this pathway, dopamine has to be released and transmitted to the striatum from the substantia nigra in both of the pathways, direct and indirect. So in Parkinson's disease, both pathways are affected. However, if you think about the presentation of a person who has Parkinson's disease, you can see that the direct pathway is more impacted than the indirect pathway, since we can't send information effectively to promote a movement. The direct pathway is to promote movement, while the indirect pathway is to inhibit movement. However, in Parkinson's disease, and you just think about the appearance of someone who has it, we see the inability to promote movement more than inhibit movement. So this is where the problem with Parkinson's disease starts to occur. And I'm going to show the image of the flowchart again. However, just look at these two images. The image on the left, schematic of what we just saw, normal expectation of how these pathways function. The image on the right is the same exact pathway, but it shows what's actually happening at a physiological scale with a person who has Parkinson's disease. So look at the two. Are there any differences whatsoever between the communication within the pathway? No, the structures look the same. The arrows are still pointing in the same directions, going to and from the same locations. The only difference between the two is that the very first step, where you see the dopamine being released from the substantia nigra to the striatum, left side shows that there's a solid black arrow. Right image shows that there is a dashed arrow, and this suggests that there is not enough or maybe no dopamine at all being sent from the substantia nigra to the caudate and putamen, aka the striatum. I'm just reiterating this to make sense to you that the pathways are the same in how and where they're being transmitted. The problem lies in the step of the dopamine being sent from the substantia nigra. Now I want you to think about this. Again, the body in general is only going to spend its resources, thus energy, on structures and processes that are continuous. So for example, if I don't strength train, I'm going to lose my muscle because my body is not going to bother expending energy for something that's not constantly being done. So the same thing is going to happen at the level of the substantia nigra. If I have a normal functioning substantia nigra and I'm producing enough dopamine, as I always have been, this particular pathway, which is called the nigrostriatal, so nigra for substantia nigra and striatal for striatum, right, this pathway going between the two, this is going to continue to exist properly. However, if this substantia nigra is not functioning and dopamine is not being sent through this pathway as expected, and if anything, significantly less, this pathway, the nigrostriatal pathway, is going to degenerate. Our body is not going to bother expending the amount of energy that it normally would to maintain this pathway. This pathway does not degenerate immediately. It is a progressive process. Let's put everything together. The cortex is still sending the information that it needs to send to the striatum. This pathway is totally, completely fine. The nigrostriatal pathway between the substantia nigra and the striatum is not functioning the way that it should. So this means that everything downstream in both of the pathways are going to be affected. Remember what I said earlier. There needs to be a threshold that is met and is required for our physiological processes to work optimally. Well, the lack of dopamine does not allow for that threshold to be reached. So everything that should happen next, so the information that should be going to the substantia nigra, should be going to the globus pallidus internus, then to the thalamus, then to the cortex, all of this does not happen. Or if it does happen, it happens at a significantly lower level. Well, if my direct pathway, when it's functioning normally, is trying to tell my arm to raise or my leg to walk, but this pathway isn't working, it results in me not being able to raise my arm or initiate walking, right? Now, of course, there's always a spectrum to how this occurs. If you have a mild degeneration of this pathway, it's probably going to be associated with a mild presentation of Parkinsonian symptoms. If this pathway is significantly degenerated, it would make sense that this person would probably present with a significantly reduced ability to plan, to initiate, and to execute the movements that this person would like. Now, yes, there are ways to treat this, but I will say this is not the point of the lecture. I do have a lecture that discusses Parkinson's disease as well as treatments, so check out those videos. With Parkinson's disease, definitely the biggest sign and symptom that you can tell a person has it is probably their motor impairments. However, understand that this is absolutely not the only thing that people who have Parkinson's disease have impairments with. All the way at the beginning of this video, I mentioned that the basal ganglia also has involvements in things like cognition and emotional state and the reward system. Well, if the pathway that involves the basal ganglia is not functioning properly, wouldn't that mean that everything that the basal ganglia is involved with is going to present with an impairment? So that's why, again, with respect to cognition and addressing the impairments, we want to do things like dual task testing. Emotions, apathy, engagement, interest, these are also things that are affected in those who have Parkinson's disease. So these are all things that you'll notice this person has a change in when this disease progresses, or at least initiates. Speech and the volume of a person's voice and the ability to chew and swallow, these are also affected in those who have Parkinson's disease as well. There are muscles that we need to use to help us speak and swallow. Well, motor complications are exactly what happens with Parkinson's disease. So even though, as physical therapists, we think about our major muscle groups being, in the legs, the trunk, upper extremity, the neck, I feel like the ones that we do forget are muscles like these, right? The ones in the jaw, the muscles that help with mastication, the muscles that help with swallowing. And yes, of course, we can't see these directly, but they do exist and they're affected. So, you wouldn't want one of your patients who has Parkinson's disease to end up choking on their food. And understanding these kind of things are really important as a physical therapist because, if a person is coming to you with Parkinson's disease at an outpatient clinic, unfortunately, sometimes these patients are not educated on things that they might need, like speech therapy that can ultimately reduce their chances of choking on something. So just keep in mind that there's a lot that goes into this. So we as physical therapists should not be so single-minded in thinking that there is only a motor complication. These are the only things that they can work on. You should, kind of refer out or at least suggest them to go to their neurologist and see what else they might need help with, them and their loved ones. Hopefully this lecture was helpful in helping you understand the pathways a little bit more and make sense of it. If you're studying for the NPTE, check out our courses at sptwithme.com. Lastly, check out these references if needed. Catch you soon.